think one of the things that I learned in the military is it's not just about the long-term outcome for the patient, which is really quite important, but we really need to focus a little bit on short-term success for these patients, because the military patients would often convert to amputation if we really weren't getting out of the gate early and getting them back for recovery. So this is a patient of mine. He's in the public domain now, so later on we'll use his name. But he had this bad 3B open tibia fracture, but as most seasoned people on this meeting know, the foot's the real problem here, and this is really a limb-threatening injury that could go on to amputation. So, you know, conservatively, it would take months and months and months to reconstruct this, and he would be convalescent during that time period. And it really changed my philosophy to take care of soldiers like this. You can see him scuba diving with his frame on and hiking and really active, and working with these soldiers really changed my approach to it. And so you can see even during the recovery phase, we're very, very aggressive, even with his frame on, for how we train these people and get them going with their rehab. And this is the same rehab pathway that has really made a lot of news lately with the Center for the Intrepid, working with a certain professional quarterback who's really made an amazing comeback. So we really have to start asking ourselves, this is what I started asking myself, you know, are we designing rehab for the surgery, or should we design the surgery for the rehab? And this is how I got into a topic that we'll talk about later on in the course, which is outpatient non-union surgery, this on-path work. And the concept of this is to get people in and out very quickly, have them immediately weight bearing and getting on with their lives, even with a non-union. It means we're doing the surgeries through little poke holes, but the surgery is about the same as we would normally do through a bigger surgery, but using combined implants through small incisions, and some of the pain control things that we'll talk about later on in the course, to get these people out of the hospital, and really done in a hospital-based outpatient department. So really done as outpatients, and we'll show you some results of that when we talk about this specifically. You say, well, can you correct deformity in that setting? Yes. Again, combined implants, immediate weight bearing, small incisions. And so you can do that kind of work even in the outpatient setting. There's another case example of a patient with a tibial deformity. He has a non-union down below, and he has a proximal tibial deformity from a segmental injury. So you do your plan, which you know, there'll be several talks during the course to help go through how to do these plans. And this is how it's done: percutaneous drill bit osteotomy, no bone graft, blocking screw, weight bearing is tolerated. The guy goes home the same day. This is him at 4 months and at 9 months. You see how rapidly they heal and axis and length restored. And it looks like they've had bone graft, and really what it is, it's a minimally invasive surgery where you do a percutaneous osteotomy and let the reamings take care of the rest. You have larger deformities that you'd want to deal with. You say, well, you can't just slam a nail in that thing and correct it. And so we had a deformity like this. This is about 4.5 months out from initial non-operative management. This is a pretty big deformity because you see it's in 2 planes. There's a lot of procurvatum going on here, as well as the varus. This was a few years ago. And so what do? We do a technique that I learned from my colleagues here, Dr. Rosbrook and Dr. Fragman, right? So you set up a frame because you need to do a gradual correction, but I'm very careful because I don't want any of my fixation in the path of the nail. Now, truth be told, some of those wires at the bottom, they just have to be because it's such a short segment, but you grab the foot and you get most of your fixation from the foot, which is not going to engage the nail. And you know, people say, well, do you have to open it and do releases? If you open it and do releases, this is going to heal very, very slowly. And you say, well, then how do you get it to heal? And do you drill it? Do you this? Do you that? Turns out there's a lot of data on just closed distraction of non-union. I actually got to visit Dr. Freire in South Africa as well. And he has a very, very large series of closed distraction of non-unions, which really came from the original Russian techniques, where you just distract the non-union, you get distraction osteogenesis, and it heals. And so that was the strategy here. So this is at day 6, we're starting to correct the deformity. Day 13, deformity is corrected. The patient goes back to surgery within 2 weeks, converted to a nail. Partial weight bearing immediately in a cam boot, full weight bearing by a month. So this is a 1 month from the initiation of treatment. Patient is full weight bearing. She goes back to work. She's a small business owner, and she goes back to work immediately, running her small business. Another thing to really talk about is limiting donor site morbidity, and Rob asked me to include some stuff about soft tissue coverage in here. And this has been a big area of interest of mine for about 15 years. I will point out that that this group was really instrumental in leading the way with translating some of these techniques from Russia and from Israel to the United States. And the first publication that I knew of in the United States was this one by Rob. And these are the kinds of things that really helped us when I was on active duty, because we had situations like this. So this is a guy with a proximal tibia fracture, and you say, oh, he's got a segmental defect, proximal tibia fracture, you know, maybe he's got a wound there, you can cover that with a gastroc flap. The problem is he had burns all throughout, and his gastroc had multiple penetrating injuries in it, and so it was non-viable for rotation. So ended up doing a shortening and angulation on this gentleman, and then you gradually lengthen that back out, straighten it back out, and get the rest of his length at another site. And you can see, you know, the concept that people have that aren't familiar with these techniques is that the patient is not going to be able to tolerate it. It's going to affect their range of motion and their functional outcome. And what I can tell you is that, you know, carrying a 120-pound hog up the mountains in Northern California is pretty, you know, I don't think that we have a functional outcome test that involves this, but that's pretty impressive to me. This is him hunting a few years later with his son. And, you know, the next iteration of this is really standing on the shoulders of giants is what about these massive defects? You see this, this wound on the left. This is not something you're going to be able to just fold up the leg and close. There's no way. There's not enough tissue. There's not enough tissue left. It's also not something you're going to be able to close with a muscle flap. Just no way. It's huge. You'd have to have a big latissimus flap or something like this. So this is a patient severely injured, bilateral injuries. He does not want the donor site morbidity of another big flap. So fold that up, bayonet opposition. So you basically get the gastroc flap to cover it all, and then you slowly, through distraction osteogenesis, you get it back out to length and get it to heal. It's really interesting as you drag this bone through the muscle compartments, it actually leaves bone behind it. And so you have to be pretty careful to make sure you get your axis restored as well, because it looks a little bit funny when this bone heals all in. And this is what his soft tissue looks like. And so you see he's got this massive flap that covers almost his entire leg. This is just a gastroc flap that normally wouldn't get down that low. And so if you can't bring the muscle to the bone, you bring the bone to the muscle was kind of the concept. And a lot of these techniques are really summarized, both the original work done in Israel and the work that include the work coming out of HSS, and Sarah Pieri actually wrote this up in a really nice review article that went into the Journal of Orthopedic Trauma. So other aspects of limiting the morbidity of the reconstruction and really getting outside the way that we were traditionally taught and the way that we traditionally thought about non-union and deformity surgery in the trauma and pediatric worlds. So there's a patient that had a non-union. He was nailed, dynamized, still didn't heal, had a non-union, and he comes to me. One of his bigger problems was his foot was pointing out to the side. So he had a significant rotational deformity, and that was his cosmetic issue. He was a college age kid, and that was the thing, is he wanted to go back to college. He wanted to have this done on his spring break and go back to college and not miss a step. And so, you know, traditionally trying to correct the rotation through this non-union would involve a significant amount of stripping. And so instead, what we did is, you know, when you have little tools like this, is a little bubble level that helps you determine your exact rotation, which we knew in preoperative planning how much we needed to correct. So instead of trying to correct them through the non-union site, we do a small percutaneous corticotomy above the non-union site in the diaphyseal section that corrects with perfect rotation. It corrects there, and the increased blood flow of the corticotomy, which we know from Jim Aronson's work, increases the local blood supply 3 to 5-fold. You expect that that's going to heal the non-union. You do upsize the nail a little bit too, and so that helps as well. And so you get a nice rotational correction. For these, if I'm able to correct a smaller rotational correction, even some of the bigger ones, I'll stabilize the ankle and I'll correct it, and I won't necessarily cut the fibula to decrease the morbidity there. And so here you see him healed quite nicely with his rotation corrected. So this is not a college age kid, right? This is an older lady. This is a very, very common thing that I see in my practice where an older person has a distal femur fracture that goes on to failure. These eccentrically loaded lock plates have actually not done very well for distal femur fractures, although it's been significantly adopted. And so she's almost a year out from this injury. She's got a bunch of broken hardware and she's got a significant deformity as well as a non-union. The interesting thing is I showed this case at a meeting. It was a DOD meeting, and in the audience was Anna Miller out of Wash U. And everybody's got all kinds of questions about this sort of stuff. And she asked the critical questions like, how'd you get that hardware out without destroying the biology? And that's actually the hardest part, is trying to figure out strategies to get this hardware out. This broken plate that you see here, or this loose plate you see here, and these broken screws through small incisions. It is possible. And if you do that and you preserve the biology, you can still be minimally invasive, limit the morbidity, and you really allow that patient's local bioreactor to still exist. If we open it up in a traditional way and take down all that biology, then we have a little bit of problem. And I think that's where you need more things like augments to your bone graft or autograft. Whereas for me, for about the past 10 years or so, I've moved completely 100% to allograft alone for non-union surgery. And so I put it in with the little tube that you see there in the middle slide. And you restore her axis. We did a rotational correction. It didn't really turn out tube on tube, but her axis ended up being corrected. She broke through one of the screw holes. As I did my percutaneous rotational osteotomy, it broke through one of the screw holes, so nothing ever goes exactly as planned, but we're able to get the axis and rotation restored. And here she was at 5 months. Everything is completely healed. She was immediately weight bearing, went home the same day of surgery. So you say, well, what about the more complex stuff? What about length? Can you do this with and limit morbidity in someone that has a non-union or a deformity with a limb length discrepancy on the femoral side? And here's a lady that had multiple good surgeries done by a good surgeon that I know, and she just kept getting shorter every time. She's a nurse, and found me through a variety of ways, and then came down to have some discussions about some of her options. For a limb length discrepancy like this, in the past, we used to do all kinds of things like put X fixes on these people. That's quite a morbid procedure now. I'm thinking about putting an X fix on someone's femur to do this. So instead, we take a combined strategy and do the same operation that we talked about with combined implants, plate, nail, through minimally invasive techniques with allograft for the distal segment, but also using a lengthening nail at the same time. There are new techniques available as well to potentially attack a strategy like this, but with the recalcitrant non-union here, I would suggest you should do a good non-union surgery there at the bottom. And so this is her lengthening or non-union surgery. You can see the massive amount of allograft. I do put a lot of allograft in there because the body does resorb a fair amount of it, and then it remodels over time. And this is her a year out. She was already back to full duty, working as a bedside nurse and doing quite well. Again, decreasing convalescent time. A lot of times if we go through some of the more elegant reconstruction strategies, it involves a significant period of non-weight bearing. And so this is a 74-year-old, very, very thin female. She's 6 months out from this injury. Again, this is another common thing that I see in my practice, these broken cephalomedular nails. This particular implant has a published bad track record. It's actually the dominant nail in the market, and has a published track record for breaking just like this. And so this is her situation 6 months out. She's got a she's got a deformity which has gotten worse over time. And that's part of the strategy, is like, how are you going to correct this deformity without annihilating the local biology and really giving her a big operation? And so again, remove the implants percutaneously and start to apply your new implants. If you see that on the far right, you say, wow, that's a lot of distraction. Why is it a lot of distraction? Because you can actually correct a coronal plane deformity from a hip with traction. If you add traction, you get valgus. You decrease traction, you get varus. And this is something that it's really sort of interesting to see, because a lot of my understanding and refining of this technique was actually probably in Russia, where they put people on fracture tables for just about everything, or put invasive distraction on everything, whether it's a humerus fracture or whatever they're applying the frame for, but the majority of the correction comes from that. So you get your over distraction, you correct your coronal plane alignment, you lock your fixed angle implant, and then you go ahead and bang the implant in. You take off your traction, you bang the implant in to get some good bony contact, as you see on the right. Now you still have, you know, what is essentially an opening wedge correction on the medial side, but you've never opened that side, you've not looked at it, you've not put a retractor over there. You apply your secondary implant, so you have a nail plate combo again, and then here comes the little tube. And this is just this is a tube from a suprapatellar nail. Basically, I just put the bone graft through the suprapatellar nail tube, and there she goes. Home the same day, weight bearing is tolerated, beginning to heal at 5 weeks, already ambulating independently with a walker, and at 6 months she's pain-free and is already really starting to bridge this. And that's really the strategy, is to get people up and going and back in their homes right away. This is a lady 5 months out from this humerus fracture, showing 0 signs of healing at 5 months out. You know, this is she had a very, very long spiral fracture. So this is a pretty big schwack if we do a traditional open reduction with iliac crest bone graft. Is probably the book answer for how to treat this humeral nonunion. With this limiting morbidity philosophy up front. It's a small anterior window and a nail, which is somewhat blasphemy for this deformity correction and non-union surgery. And this is her at 2 months, and then 6 months healed with good alignment, good function. What about infection, right? You can't possibly think about treating infection as an outpatient. Well, this is kind of the new adventure here, right? There's a big paper, the OVIVA trial, that came out of the UK that demonstrated that oral antibiotics were actually not inferior to intravenous antibiotics. We kind of got into the 6 weeks of IV antibiotics deal for osteomyelitis with really not much data to support getting into that. And it really has become the gold standard without much data to support it. As we talk about infection, I do have to say I have a very, very strong bias towards local delivery. I know I'm in safe company here with this group because y'all are thought leaders in local delivery of antibiotics as well. Sometimes it's a little bit of a tussle when I get into some of the stuff. The real challenge is not only biofilm. So you have biofilm that is not that protects bacteria from being available to antibiotic. The bacteria in biofilm are also quiescent, so they're not replicating, and most of the antibiotics work during the replication process for bacteria. But then there's this little entity that is super scary of bacteria that live inside living cells, inside the scanning electron micrograph of bacteria that makes it inside living cells. It gets invaginated in there and becomes quiescent and only begins replicating and becomes active once that cell is lysed by a drill bit or a reamer or a saw blade. And this is why infections can come back with secondary surgeries. There's a lady, unknown reason, she developed osteomyelitis. She had this cortical defect, comes to see me, MRI. Of course, she sees the tumor service to make sure this isn't a tumor. And the consensus is that it's osteomyelitis for an unknown reason. So she gets a big saucerization, remove a lot of that bone, not a segmental resection because she actually had reasonable bone on that lateral side, leave that antibiotic-coated nail. Because she had a metaphyseal defect that did not have good contact with the nail. Contact is important. We had a paper that showed that. And so I added calcium sulfate pellets in addition. As far as the antibiotic-coated nail, I think a lot of people have recipes now. This is our recipe. Basically, the concept was to make it as cheap as possible. And even we dropped the gentamicin-loaded cement and just have regular cement. We've made a video for how to do it. It's pretty easy, and this is all stuff that's readily available. The tubing is readily available. That's one of the challenges, is getting the tubing. The silicone tubing that we use is from the perfusion set, but DNC tubing or perfusion tubing works the same. Our hospital would not sterilize other tubing that's become popular for this, and so this will be on the OTA website as well, but it's on my YouTube channel as well. You can just Google Restore Limb Channel and find it. And so we're really about 2 years into this musculoskeletal infection outpatient pathway, and part of that involved really getting buy-in from our infectious disease colleagues, and it came just in time, right? So this is about 2 years old. This is pre-coronavirus, and so what we do is I'll treat these patients in our outpatient center, and then we do an EHR message to their to the ID people. We start the patient immediately on an oral antibiotic they see ID within a week, who either continues it antibiotic, narrows it, or focuses it. On occasion, they'll go ahead and put them on a PICC line. There still are some that have a bias towards IV antibiotics, which is fine with me. I'll let them make that decision. But what I don't want is this patient automatically admitted to the hospital to get a PICC line and waiting on cultures and things like that. So this is entirely done, come and go the same day. Coated implants, osteomyelitis surgery, even some acute infections are part of this group as well. And you say, well, single stage infection treatment, it's a little bit aggressive. It is, and I know that there are members of this group that have a lot of experience with it. And these are some of the things that are next frontier for us as well. The 35-year-old lady, very, very nice. She's an accountant who works here in the Charlotte area. She was on a scooter in Mexico on a vacation, broke her arm, and they said that she would die if she didn't have her arm plated in Mexico. And so they plated her arm. She has a very, very dense radial nerve palsy, and she has she's a bit of a heavier woman, so she didn't have any drainage, but she had this unusual skin rash all over, elevated inflammatory marker. So the suspicion that she was infected was quite high, and it turned out that she did have an infected nonunion of her humerus. And so typically I would put some graft in this, and so because she is infected, she got a single stage operation. We got some good bone contact and no graft. And you say, well, that's the funniest looking plate I've ever seen. What kind of plate is that? Well, we made that one. It's a regular compression plate. And we use the same tubing that we use to do the antibiotic coated nails. And we squirt the antibiotic cement in there, put the plate in there and smash it. The sets aren't heavy enough, so you got to have someone kind of lean on it a little bit to smash it. And then we pre-drill it, because if you don't pre-drill some of the holes as 4 or 5, it doesn't suck the plate down to the bone. So I'll drill a couple of holes as 4 or 5 holes on either side of the plate, so it sucks that plate down to the bone. I use a plate as a template for my deformity correction, and then your other fixation screws. And I'll even countersink a little bit so it doesn't shatter the cement when the screws go in. And your other screws, it's sort of interesting because the acrylic cement grabs them, and to a certain extent, they become fixed angle screws. So this is what she looked like at 2 months after her surgery. And this is what she looked like at a year. She was healed. She went back to work almost right away. I did not do a secondary bone graft. At this, I brought her back at the 6-month mark and took an x-ray, which I don't have here. And she started bridging the darn thing. So I told her, I was like, you know what? You have no pain and you're starting to bridge it. Let's just wait it out, and maybe you don't need a bone graft. And that's exactly what happened. Although I'd even talked to her about potentially bone grafting it. Elimination of pain generators, I think, is really part of this in deformity correction. It's really important to understand this, especially around the foot and ankle. Pain drives the outcome. It's not just the deformity that drives the outcome. Pain, pain, pain. So if you actually look at foot and ankle hindfoot scores, 80% of the variance, which means 80% of the difference between a good score and a bad score, comes from a single dimension, and that single dimension is pain. And so when I think about hindfoot deformity, I think about pain as well. This is true in both the military and the civilian setting when it comes to pain driving their outcome. And so this is a patient. He actually works at our hospital, and he came in. It was actually a pretty emotional story. Brought pictures of his daughter that he couldn't play with because he had these multiple injuries. And this is really from playing sports. He's an athletic guy and had this problem. And so he wants to go back to high level activity. And so just doing fusions on him may not get him back to what he wants. Fortunately, in the military, and again, this has made some press lately, we developed this return to run clinical pathway and translated this to the civilian sector. We call it the return to performance pathway. But we can take people even with a fusion, right? And so you say, well, people with fusions can't go back to high level activity. So there's a guy that I did an ankle fusion on after an open blast injury. And this is his function now. It's a 36-inch box jump, which I saw James Blair's on there. He can tell you I was not much of an athlete in the Army, so I wasn't jumping on any 36-inch boxes to demonstrate this for the patients. But you can see he's able to get back to running way faster than I could run with uninjured limbs. And one of the things that he really wanted to do was go back and play softball, which when you tell an orthopedic surgeon, hey, I've got this limb-threatening injury, I want to play softball, it seems a little bit ridiculous. But that's what people want to do, and really understanding their self-efficacy, understanding where they want to be is really important. And so we were able to show that in a relatively large cohort of patients, that we're able to get them back, improve their function, get them back to the type of things that they wanted to do, even 2 years out from their injury with this rehab pathway. And the fusion patients did quite well. The isolated subtalar fusions, of course, did the best, but we had ankle and TTC fusions that did quite well and improved their performance with this pathway and a device like this. And so here's that patient that I said brought pictures of his daughter and wanted to get back to activity. He did get a brace as well and do our rehab pathway. This is his gait with a brace on. You can tell if you didn't see the brace, you would not even know that he has any type of an injury, and certainly not a TTC fusion, which some people will say you better just cut that leg off rather than fuse him. And he's gone on to be a multiple race runner. I don't have the picture in here, but he just recently finished just last year a full marathon as well with a TTC fusion. So we showed some horrible pictures of Ryan at the beginning. That was the foot you saw that was blasted open. So whatever happened to Ryan, he can run and jump and do all kinds of things. What did he do? Ryan's a special operator. So Ryan is he's a bomb disposal guy. That's what he does. And so guess what he went back to doing? He went back to finding IEDs and getting rid of them to protect his unit. And went back to full active duty. And you know, these guys, these limb salvage patients, they serve in anonymity. This is not like having an amputation and going down range and deploying. They serve in anonymity. No one knew what Ryan has actually been through when he served. His unit, of course, knew. This is him with his Seahawks flag. He brought the Seahawks flag on every deployment and unfurled it everywhere he went. Ryan didn't just serve. Ryan actually served to the level of getting a Silver Star Medal, which is one of the highest commendations for valor that's possible in the United States military. You know, he's a longtime Seahawks fan. Actually, you can watch a YouTube video of him raising the Seahawks flag, which is pretty emotional. I would challenge just about anyone not to come to tears watching this. Ryan has actually become an author now. He wrote a book called Tip of the Spear, and it talks about his road to recovery and back to deployment. And if you want to hear what's in his commendation and what he did while he was back on service, Jocko Willink, who we all know and love, just recently hosted Ryan on a podcast. It's quite a long podcast. It's about 3 hours, but definitely worth. Definitely worth listening to.